Okay, so I know there was a question, I think it's in chat now, but my email is up here again, just so you have my information. And this is one of my favorite things to talk about. I love talking about tubes, and I think it's, for the clinicians on the call, it's fun, especially if there's any dietitians on here. It's sort of eye-opening because we don't get a lot of that information and experience when we're in the hospital setting. It's when we get into home care, we become, it's necessary to understand how to troubleshoot and things. So, and I think that, you know, for you as consumers, again, I can't emphasize this enough. This is your prosthetic. So I want you to think about it like if somebody were having a prosthetic leg or hand, it is customized and fitted and designed to meet your needs. And I want you to think about your feeding tube in the same way. It's not you get what you get and you don't pitch a fit, you know, you get to have a say in this, and you kind of get what you get the first time, but then once you've got your stoma and it's mature and you're able to navigate through the healthcare system and have your tube changed out, you get to advocate for yourself. And so, you know, Rick talked about it yesterday with, you know, his lifestyle. He's been able to live a rich and full and active life because he has customized his prosthetic, his feeding tube, and the way he feeds to meet his lifestyle. And so I hope this information empowers you to think about your feeding tube in that way. And I hope it opens the eyes of any clinicians on this call to think about the feeding tubes in a different way, because it's not a one size fits all. You have to meet the device to, match the device to meet your needs, and everybody's needs are different. So, all right, so here are my disclosures. And I was thinking a lot about how I wanted to approach this, and I like to know what the needs are from an education perspective of my audience. And so I started asking consumers that I communicate with, what do you wish you had known earlier in your journey with a feeding tube? Because it's a very rushed experience. When you first get a tube, there's not a lot of information. You are solving problems on the fly, trying to figure this out. Sometimes you have a lot of support and education, and sometimes you don't, right? So now here you are looking back at your former self and thinking, okay, if I had known this earlier in my journey, it would have impacted my life. And that's my goal, is to share information that helps you thrive on your journey, but also, and most importantly, have a good relationship with your feeding tube so that it's not this problem and challenge and obstacle, that it just becomes, it's your prosthetic, it's what allows you to thrive and live a rich, full life. And so that's the tone that I want to set starting this presentation. But let me just kind of cover some of the answers that I got. I'll share this with you. So one of the answers was, I wish I knew what my options were as it relates to feeding tubes, because you don't get, you're not given a menu when you're in the procedure room. Say, which one would you like? Which one do you think would really fit your needs? And they're just not thinking about that. So once you know what your options are, then you get to self-advocate, right? So other responses were about the ENFIT design benefits in the home setting, and Vicki did a spectacular job of that earlier today. So I think we've covered that. How to best care for your feeding tube and your tube site, and Mary covered that yesterday as well. So, I think we're doing a really great job. I didn't share my survey with Oley before this presentation, so I'm here to tell you I think we're on target. And then lastly is there's always questions about low profile tubes, because most people get a dangler, when they first have a tube put in. It's unusual to get a low profile device on the first tube placement, but it does happen in certain circumstances. So people want to, get a little bit more information about how to get that low profile feeding tube and what all is involved. So here's my menu. This is what I'm going to try to tackle. And it's going to be fairly informal here. I'm just going to show you, I'm going to change camera positions. This is where this is going to be a new format for me, where I'm going to kind of show you what I've got here in front of me. But I want to cover the following. So here's what I'm going to tell you. I'm going to talk about the anatomy of a feeding tube, how they're designed, what it looks like on the inside, because you usually can only see what's on the outside. I'll talk about the difference between a PEG tube, which Dr. DeLagey was illustrating some PEGs in some of the pictures in his prior presentation. So I'm going to compare a PEG to a balloon gastrostomy and what that looks like. I'll show the difference between the dangler style tube and the low profile device. And then I'm going to cover extension sets. So Lisa in her presentation yesterday was referencing right angle and straight extension sets, and not everybody knows what these are. So I'm going to kind of show you what the difference between the two and when we might use one versus the other. ENFit versus legacy port, I think we've covered that pretty well, but if it might come up again as I cover things. And then Lisa said something yesterday too. So I've been paying attention and taking notes, trying to think, like, how can I fill in some gaps here? She was talking about an O-ring syringe. So I'm going to talk about what that is and also show you different syringe styles, because for our bolus feeding consumers, having options with syringes, and there are options, can sometimes be life-changing, believe it or not. And then I'm just going to cover the difference between small bore and large bore tubing. I'm going to show you the difference in extension sets and what the difference looks like in a gravity bag as well. So that's on my list. We'll get to Q&A later. Okay, so this is where it gets interesting. This is where I change my camera. I'm going to show you. Oh, it's not. I have the wrong camera on. All right, let's see if I can change my camera. Not going to let me change my camera. Sorry, guys. Okay. Well, I will do it in front of the screen. So I'm going to stop sharing. And okay, so we will start with the anatomy of a feeding tube. So I want to show you, I'll start with a balloon style gastrostomy tube. And this is a single piece. This has a balloon, which is the internal retention device. And then this is your external bolster. And it's important to know that these are adjustable and these move. So it's important to know, where a good setting is for your bolster so that you can have a nicely fitting tube. Now, when you look at a feeding tube from the outside, generally, you're not, when you've got the tube implanted, you can't see what's on the inside, right? So how do you determine whether you have a balloon style gastrostomy tube or you have a PEG style gastrostomy tube? And this is a PEG. So Dr. DeLagey was showing pictures in his last presentation with internal retention devices that look like this little bolster disc. And these are soft and flexible so that when it's time for these tubes to be removed, they're actually removed by traction. And so sometimes these tubes can get dislodged. They can accidentally come out, or patients can pull them out. So sometimes that's what I saw most of the time in the acute care setting. When these became dislodged, it was from somebody pulling on them, but that's not too common, thank goodness. And then this external bolster is what is adjusted to make sure that the tube is fit properly. And so when the tube is on the in place, and this is your stomach lining, you want to make sure that the tube is actually set so that the internal bolster, whether it's a balloon or this little soft pliable bolster, is resting on the inside lining of the stomach. And then the external bolster should be set appropriately. So we can get leaking at a Gtube site or a Jtube site if this bolster on the inside is sort of pushed away from the inside lining of the stomach. And so if it's not fitted properly or it's not adjusted properly, you can have leakage. So going back to the outside of the tube, which is generally all that you can see, whether you're a clinician assessing your patient or you are a consumer who is just trying to figure out what kind of a tube you have, the difference here is that you've got a PEG tube, which is percutaneously endoscopically placed, so it's placed in GI, only has a feed port and maybe a flush port or a med port, but the balloon style gastrostomies, which are all one piece, they have a feed port, potentially a med port. Some do, some don't have this extra med port. And then there's this extra balloon port. And so if you have a balloon port on your tube, and it'll have some writing on there that tells you the French size and how much water should be in that balloon, this is telling you that you have a balloon style retention device on the inside. So that's how you can determine whether you have a PEG, which is this guy, or a balloon style gastrostomy tube. And it's important for you to know what kind of prosthetic you have, what sort of device you have, so that you know what your options are when it's time to have the tube replaced. So when this one is removed, again, it's pulled out via traction out the stoma. When this one is removed, you deflate the balloon, and that's a fairly simple process with a syringe that's designed to fit in that balloon port. And remove the water. And then when it's time for that tube to come out, you just slide it out. And you can replace it with something like a button, if that's what you want to transition to. So this is your dangler style G-tubes. Again, this is a balloon gastrostomy, and this is a PEG. All right, so now let's talk about low profile devices or balloon. And what I have one example of like balloon style buttons, and then there's lots of different brands and options, well, not lots, but there's a few different brands and options, but there's different internal retention styles. Most of what I see used is this balloon style retention. And then there's a version that comes with a plastic soft internal retention, so there's nothing to pop and accidentally leak and then fall out, but it does require a little tool to stick in there and stretch this out for removal and replacement. So that's what that is. And then these balloon style tubes come in all different shafts and French sizes. So let's go over the anatomy of a low profile device. So this is your balloon port, and this is how you inflate and deflate the balloon. This is where you open up the port and connect your extension sets when it's time to feed or flush. This is the shaft of the button, and this comes in all different sizes. And so the difference between a dangler style tube and a balloon and a button style tube is that this has to be measured and sized to meet to fit you properly and to fit your stoma length. So I've got a couple different options I can sort of compare and show you the difference. So here is a 0.8 centimeter, just a little one for an itty bitty, and it's a 12 French. So the 12 French is telling you about the diameter or the thickness of this shaft, where the centimeters are telling you how long it is. So it's 0.8 centimeters. So this is designed for a little baby. And then here's a bigger one that has a 18 French. So the diameter of this one is 12 and the diameter of this one is 18. So you can see it fits a different stoma size. And then the length is 0.8, so just less than 1 centimeter, and this is 2 centimeters. And so you can see the difference there. So if you've got a feeding tube in a baby who's growing, eventually they're going to grow out of this one and they're going to need to go up to a 1 centimeter and then a 1.2 centimeter and then so on. And so they get resized and refitted as the child grows. And then for adults, these can be adjusted and resized depending on weight gain or weight loss. So that's important to keep in mind. And this information and understanding how to properly size a tube, a button style tube, is really important because it impacts the quality of life as it relates to leaking and any problems with tubes that don't fit quite well. Because if you have a tube and you have this much of it sticking out of your stoma, what that means is when it's all the way down here, what it means is when it's like fitted on your stomach lining like this balloon is far away from the internal lining of the stomach, and you can have leakage in there. So if you've got too much play between the inside lining of your stomach and the outside of your abdomen, and you can see too much of that shaft, then you're going to have more leakage and more problems. So you would need to resize your tube, and there are stoma measuring devices that can be used to actually measure your stoma tract. And so some people do that themselves at home, but most of the time that's done in clinic and they can be sized. So this little balloon deflates, you insert it into the stoma just like you're placing a tube or a button, and then you inflate this balloon with water, and then this little disc slides down until it's touching the abdomen and resting gently. And once it's got a good fit like that, you know it's not fitting. You don't want to size it when it's fitting like that, because then you're going to have way too much play, right? And you're going to have leakage coming out. So you want to gently pull and allow that disc to sit gently on the skin, and then you can read the measurement. There's little centimeter measurements on here. And the stoma measuring device needs to coincide with the brand, the manufacturer of the actual tube that you're sizing to fit. So that's what this is. And I find that sometimes these are used, but a lot of times I find that it's kind of a stab in the dark. If you're sizing estimation is a practice that I've seen with nurses and physicians that often they're very good at it from experience, but when sometimes I've seen it not quite as effective because the sizing isn't quite right. So that's when you might want to go verify your stoma length with a stoma measuring device. Okay, so let's talk about extension sets. So this is a right angle extension set, and this is what connects to the button to allow access for feeds. And right angle extension sets are called right angle because they have that little turn, right? They clip in and then they right angle. And you'll notice that the tubing itself is really quite narrow. So these are designed for pump feeding. This is not a good option for bolus feeding because it's going to slow down and make it harder to allow that formula to go through, whether you're pushing it or allowing it to go via gravity. So this is really designed for pump feeding or continuous feeding for two reasons. It's got that smaller bore size, which can help control flow, but it also lays conveniently off to the side and out of the way. So that's the main design feature of that extension set, is to get it out of the way. Now, a straight or bolus style extension set, these are great for water flushes because it can allow you to flush water through without a lot of resistance. And for drainage, so some people are able to drain or vent. This is a nice option. And notice the difference in the bore size, right? So this we would call a small bore. This straight extension set has a much larger bore, so it can handle more volume at a faster rate. So it's really designed for that bolus style feeding, especially if you're using thicker formulas. Right. We talked about ENFit versus legacy, and as a refresh, the buttons themselves are not legacy or ENFit. They're neither. They're agnostic. Okay, so the buttons have not changed in that way. It's really about the extension set and the end of the port, right? So here's this is a bolus style. This is your ENFit extension set, and then there are legacy extension sets as well. I don't have one handy. Okay, syringe styles, I want to touch on that. So this is a, catheter tip or end-fit tip syringe, and this is the most common, where you can see this sort of plunger that you can have your fingers pull back on. But then there's also syringes that come with a thumb ring, and this can be easier for some people to manipulate, just because they're sometimes hand dexterity can be an issue. So just know that you have options as it relates to the back end or the plunger of the syringe. And sometimes these things can make a big difference in your ability to feed and flush, just because you're doing it on a regular basis. Then what you'll find, and I don't have an O-ring syringe here, but I want to describe it to you. So this is a typical gasket on a syringe. It's got this wide rubber gasket, but an O-ring syringe is a much thinner, more narrow gasket. And so it provides less friction. And those O-ring syringes, at least I was talking about that when she was talking about blenderized foods, because when you've got this larger gasket here, it can offer more resistance and can be a little bit harder to manipulate. But the O-ring syringes, not talking about this is a thumb ring, but the O-ring is just this rubber gasket is much thinner and more narrow. All right, so that's my syringe lesson for you. And then lastly, what I want to cover is the difference in gravity bags and large bore versus small bore. So with gravity feedings, you do have the option for a small bore bag, and the design is the same. So you have your bag, and this is a nice option for people who are pump feeding and want to transition to bolus, but you're maybe not ready, or your clinician is a little hesitant to allow that fast of a flow. You can use gravity bags with a small bore tubing to stimulate a pump. You may not need to use the pump for complete accuracy with very specific rates. You can have like an estimated feed time by setting this roller clamp and either closing it off to slow down the drip or opening it up to allow the drip of formula to go through. But I want to show you the difference between the large bore and the small bore tubing. Big difference. So this large bore gravity bag, when you put formula in there and leave the clamp wide open, that formula can flow through really, really fast. So you can't overdo it with this, but what I like about this option is it gives you the option to feed a little faster, and you get to control the rate with the roller clamp, where with the small bore gravity bags, the only way to speed up a feeding is to dilute the formula a little bit with a little bit of water, not lots, maybe just an ounce. That can sometimes help formula flow through a little faster if you're using this small bore tubing. So let me pause there. I covered the anatomy of a feeding tube. I covered the difference between a PEG tube, a balloon gastrostomy. I talked about dangler style tubes versus low profile. Extension sets we looked at. We've covered end-fit quite a bit today, syringe styles, and then this large bore, small bore. So let me do a quick pause and check in with Lisa and see what kinds of questions have got your attention.
Hi, Cynthia. We have a lot of questions. Technically, we are, are you willing to stay a little later than we had originally scheduled to answer some questions? Are you able to stay with us?
Later, if you
Terrific.
Yes,
okay.
Yep,
all righty. Then we have a bunch of questions. We'll zip through some of the quick ones, I think. Somebody is asking, her button, her Mickey is very tight to the skin. It's 20 French, 3.5 centimeters. Could I just take a little water out of it so it is not so uncomfortable?
That is an excellent strategy for sizing and adjusting the fit of a button. So absolutely. And one thing you'll notice Here's a couple of examples. These are different balloon sizes. And they're also different button sizes, so they require a different amount of water. But I want to show you what that balloon looks like when it's filled with a good amount of water, and look at the shape of that and see how it's nice. And it's got this little flat aspect at the top. That is resting on the inside lining of your stomach, and that can adjust and make it a little, it makes the shaft a little bit shorter. So if you take a little bit of water out, you can change the size of that, and it actually makes the shaft a little bit longer. So it can make the tube fit, give you a little room, but if you wanted to have it fit a little bit tighter, you can add some water and have it fit a little more secure. So that is absolutely an excellent technique, and something that once you're trained in, it's something that you can do at home independently, but you need to verify the fill volume range. So make sure you're not going too far out. Most of the time, buttons are a little bit underinflated, so they can be adjusted very easily. The other thing I want to say, because this came up in a prior, I saw a question somewhere about it, but what do you inflate this with? Obviously not air, but it should be distilled water, or distilled water, or I want to say purified, but that's not it. So no tap water, no saline. Okay, so you want water, distilled water, so that there's not any variation in chlorine or calcium amounts in the water that we have. So the manufacturers really want to verify and ensure that you have a less variables of inside the balloon, so that it doesn't rupture. But that was a bigger answer than what was asked.
Thanks.
That gives you, yeah, that helps you see that. And then this is, you can see the shape of this one, same manufacturer, different size, but see the shape of that balloon is going to completely change the experience of how it fits and how it leaks, as opposed to this sort of balloon shape. Does that make sense? So that's really important. And so get skilled at understanding balloon inflation. And also I want to say, I'm going off topic here, but I want to say too, before you replace your own balloon style tubes, before just popping it in there, this is a newer one. And so the balloon is a little stiffer. And when it inflates, you can see this. Do you see how lopsided this is? Let me get it to the right angle. So that balloon is completely lopsided because it's stiff and new. The silicone is fresh and been in the packaging. So you got to get in there and pre-inflate it and massage it, okay, so that it becomes round and completely covering the tube. Because sometimes when they're brand new, they just inflate like this. But you don't know that if you, the first time you ever inflate it, it's inside. So you want it pre-inflate it, massage it, get it all nice and symmetrical, and then inflate it. So all of these things play into the way a button, balloon, Gtube fits.
That's fascinating.
Is it just me that's nerding out on this?
No, it's great, great. So you have two questions about tightening. Well, these seem related to me. Maybe they're not. But as a clinician, how should we help or direct patients to adjust the external bolster without potentially pulling the internal bolster out or tug too hard against the balloon? And then there's another that's similar. I have a patient with a balloon Gtube that I suspect needs to be tightened. Is there a good way to do that myself without having to send them to IR?
So the second question again, it was a dangler, or does it
just says balloon?
Balloon. Okay. So if they could follow up by telling me if it's a dangler or not. But so it is a bit of an art. So when you're manipulating a tube, whether it's your tube or you're working with a consumer, it's really important to get a good handle. You've got to kind of get up in there real close. And as you're adjusting this bolster, when they're brand new, when these tubes are new, these are really stiff and hard to move. So the older they are, the easier they are to slide around. So you've just got to get kind of in there and have a little counter pressure. So when you're pulling this bolster back, you're not actually pulling the tube out. So you just got to get in real close. And you got to get your fingers in there and hold on to it to then, because this one's pretty new, so it's a little stiff, to then slide it out. So if you're paid, the second question, if you do have a consumer in clinic and you don't think it's fitting properly, you can absolutely work with the patient. You can even talk them through it. But the first thing I would do is have that, like, assuming that everything's inflated properly, is you want to pull that tube until you feel the resistance of the internal bolster, if it's this kind, or the balloon, until you feel that resistance, and then you want to set the external bolster, and there should just be a dime's width in there. Mary showed a nice little picture of a dime on her slides yesterday, just enough for a little bit of airflow, and that's how you know it's fitted properly. They don't need to go into OR procedure room for this adjustment.
Thanks, Cynthia. This one I know is something you feel passionate about. I have a low profile Mickey GJ and get a lot of leakage from my stoma. I wanted to ask my doctor if they could remeasure my stoma since it's been 3 years since they first did it, but I also tend to lose and gain weight every few months. Should I ask them to remeasure?
So for the GJ, so you've got a low I have one right here. So you've got a low profile GJ and it's leaking, not the right syringe, and it's leaking. So looking for my little syringe, I've lost it. So if it's leaking here at the stoma site, like it's coming out here, you can do that adjustment of the balloon fill volume, like I talked about. What I find with, if it's actually in the stomach, you can go full size on the balloon, and I recommend on the upper end of the range for gastrostomy tubes. What I find about low profile J tubes, and I want to be clear, sometimes these are popped in the jejunum, and this can be a J tube. So there's some semantics that you need to be really clear on from a supply management perspective. This is a G tube. That's what we call it and how we order it. But when it's placed anatomically into a direct jejunal stoma, it is acting as a J tube. So not knowing the other details of this person's question, what I would say is have an understanding. I find that direct J tubes with balloon buttons like these, there is an underinflation of the balloon because of a concern about blocking the intestine with this balloon. So I find that they are often on the low end or and even under the recommended range. So that's one where you would want to be really clear, and they leak a lot because of that. So I see a lot of leaky J tubes because of this underinflated issue. And so you have to sort of work with your physician and sort of tinker with what their tolerance level is on the inflation of the balloon, but then also making sure that it's the right stoma length. It's so simple to measure. All you need is one of these. And if your IR department doesn't have one, have them order it. It's not difficult to get, and measure. So the next time you go in for, and that could be something you do once a year, twice a year when you go in for replacements, is ask them to measure, or get one of these and bring it with you and have it used to actually measure your stoma site. This is your prosthetic, and you have a right to understand the size of it and making sure it's functioning properly. So you get to advocate for yourself in that way.
Thanks, Cynthia. I think we'll go with a few more, and then I know that we did put your email address in the chat. So so watch your email.
Okay. I'm going out of the country in 2 days. So if I'm delayed in answering questions, just putting that out there, hang in there with me for a few weeks.
And Cynthia always, she's very reliable, tell you that. Cynthia, Bethany asks if you can use a button as a G tube to decompress your stomach, or if you need something different.
Yes, in fact, people use buttons all the time to decompress, so they're, absolutely you can. I would say for draining, I'm going to disagree with Dr. DeLagey on this a little bit. I think that, and I'm going off topic here, but sort of the same topic. So venting, absolutely, this can be done to vent your stomach. Draining, I find that for some people, depending on how much volume, how often they need to drain, and if there's food involved in the drainage, that going to a dangler, regardless of connector type, whether it's legacy or NFIT, a dangler works better. So I don't think it's so much NFIT versus legacy port. I think it's button style versus dangler style that makes the bigger impact. Okay, that's my comment on that. Yeah.
I don't know if you can answer these. These are a couple of reimbursement questions. Maybe in a general sense you can.
Okay.
One is, are the NFIT drain bags reimbursed?
Oh, I saw that question. So drain bags, here's how it was for me. I used to work for an infusion company, and so we had infusion contracts, and if somebody was receiving tube feeding and we were billing for the tube feeding and they also needed drainage bags, we would provide them as part of their enteral supply kit. And we get reimbursed for an enteral supply kit, either via per diem or a daily, rate, or as a supply code level. So if you're tube feeding and you need drain supplies, we don't bill specifically for the bags themselves. It's more of a supply kit, if that makes sense. And so then we have to manage the expense of all the supplies that are being sent and compare that to actually what's being reimbursed. So sometimes we're okay and sometimes we're upside down. So when you ask, is it reimbursed? It's kind of a tricky question, because yes, but maybe not enough to cover the expense. So that's my answer to that.
Okay.
Oh, let me finish. There's more. So if we're an infusion company and our contracts are, we get paid if we're providing feeding, but we've been asked to provide only drain supplies, we don't actually get paid for that. So a DME provider has a contract that will actually allow for reimbursement of what would be called DME. If all your durable medical equipment, if all you're doing is draining, then that DME sort of payment methodology works, and that's where we would have to send people is to a DME company in that instance.
Thanks.
But that's this technicality between an infusion company and a DME company. We spent an hour on that.
Right. I think, yeah, whole nother topic. That addresses, Terry says that she uses urinary drain bags and she buys them on Amazon and uses Hypofix to connect them, and everything's paid out of pocket. So I think you've kind of gone into that with the DME thing.
Yeah.
Okay.
Yeah. And they're reusable, so it can be done affordably in that case, thank goodness, as opposed to feral bags. Forget about it. They're, it can put you upside down really quick trying to pay for those and use a new one every day and get reimbursed for it. So drainage, if you can use urinary drain bags in that instance when you're having to pay out of pocket, that's the way to go.
Great. This one is specific to your presentation earlier. It's, what is the name of the purple/clear connector for an NFIT Gtube and urine drain bag?
Read this. Enteral funnel NFIT transition connector with cap. There it is.
Okay.
But it's
Terrific.
just an NFIT to legacy adapter. That's the other thing you could call it, because there's multiple brands of these, but this is the one that I have.
Multiple brands, and they look a little different, right?
Yeah, there might be different colors or things, but here's your NFIT connector to your feeding tube that then turns it to a legacy port. So NFIT to legacy is what you would call that.
Great. We're working on an educational piece, kind of has a lot of photos and an infographic.
Photos are good.
So
you know how much I love photos. Yeah.
Yes. Yeah. Photos in this instance, they're really, you can't get around it. You need them. Yeah. So I think this will be a relatively quick one. Can you drain out of a Jtube? This maybe was for Dr. DeLegge, but I ask because sometimes when I disconnect my feeding tube, stomach acid or yellow gastric juices comes out.
Yes, so it's it can drain. You may not be wanting to. So if you've got an obstruction and something's pooling in your intestine, if you think about it, the stomach is a reservoir, and it's got this little control, the pyloric sphincter down at the bottom of this reservoir is like a time release thing that lets things drip out of the stomach into the intestine. And it's going to happen all day, whether you're feeding or not, right? Because your body's making bile and stomach acid, and that's all making its way through. So whether you're feeding or flushing or not, you could have liquids flowing through your intestine. And so it's absolutely, Jtubes can leak, especially if you're in a, in a time where you're just making a lot of gastric juices, or there's just been a release of some of your gastric content. But it's not something that you probably want to do, is drain out of your Jtube, unless that's the intervention that is needed. But I haven't seen an intentional prescribed Jtube drainage procedure.
Thanks, Cynthia. And speaking of drainage, how often does a gastric drainage bag need to be changed, and how do you clean them to reuse them?
Yeah, so you can reuse them as long as you're comfortable. I mean, they are reused for urine. You could do one a week easily. So what you would do is just connect the bag. You could connect a syringe and fill water in there and just let it flow through. So you could just use warm water in that way. Same with the NFIT, but they don't need to be sterile, and you don't need fresh bags necessarily. If you're going out and about and you don't want to deal with or have a sort of a used bag be seen, then you might want to grab a fresh one if you're going out and about for that. But at home, they can be rinsed and reused as long as you're, in my opinion, as long as you're comfortable with it.
Thanks. Okay, last one. And then I would encourage people to email Cynthia again, or email me and I will get them to Cynthia. Both of our email addresses were in the chat. So here's our last question, Cynthia, and hate to let you go, but is it hard to pull up meds? Oh, sorry, it's a statement. It is hard to pull up meds from a med cup with a short NFIT end of the syringes. I have attached a stepped adapter. Is there a better method, or are there syringes with a long end like the catheter tip syringes?
So this is the procedure she was talking about. Here's like a med syringe. This is a little 5 milliliter. And this is kind of funky to, get meds out of the bottom of a cup, a med cup. So if you put your little transition connector on there, you have this nice easy tip, and then it can come up real nicely. So when you pull back, you might have some medication still in the transition connector. So sometimes that's a major issue, especially if it's like a narcotic or something that's very precisely measured. I've had patients who couldn't have any waste because of their pain management and the limitation on medication. But then once you take that off, you can connect and push through. There are, and I don't have any with me, and I think there's info on the GEDSA website about medication administration. There's little bottle caps that basically goes on the medication bottle. If it's the liquid med, right? It is, I think, or maybe not, maybe it's crushed and flush, but if it's a liquid med that's coming out of a bottle, you can put this little cap on the bottle and the syringe plugs right into it, and you can draw back nice and clean. And then there's the straws, the medication straws. Was that part of the question, the straws?
Nope, but it fits right in.
Okay, yeah, the medication straws are cool because you can connect on there, and then it just draws it up right through a straw, which has this teeny tiny little bore that'll get down into a bottle or into a little cup if you're doing the mixture with your mortar and pestle and water. So that works as well. But a lot of home care companies aren't providing this. I think this was touched on in Vicky's presentation. So that's where I really encourage you to go online and shop around and find some options, and you can wash and reuse those. So it's just should be part of your supply kit.
Right. And they're bottle adapters as well, right?
Yes.
Right. Okay. I don't know if Joan is ready to give our closing remarks. If we don't hear from him momentarily, I'm going to jump in with another question. You know I am.
Yeah. Well, while you find a question, I think Joan just came off mute, but I want to say something before Joan starts, because I haven't had a chance to say hello to you yet, my dear. First of all, I want to thank you for, I was very mindful of this yesterday. I just want to thank you for your legacy and the way that you have set the intention of this organization, this community. It's a family, and it started with so much of the work that you've been doing over the last many decades. And you are handing off a beautiful legacy to Beth, who gets to carry it forward. And I'm so grateful to be a part of the Oley family, and I feel very privileged every time I get to speak to this community. So thank you for having me and welcoming me every time.